Welcome to another episode of Surgery from SnazzySurgeon. Today we're diving deep into the Trendelenburg procedure for varicose veins, a cornerstone in vascular surgery.
It really is a fundamental technique.
We'll walk through the critical steps, from preparation right through to closure, highlighting those key considerations for optimal outcomes in our patients.
Indeed. And even though it's familiar, looking closely at the details, the nuances, can always help refine things. Let's maybe start right at the beginning. Patient prep and anesthesia.
Good place to start. Anesthesia choices.
Mhm.
Spinal, epidural, general. What guides your decision there?
Well, for me, it often comes down to the patient's overall health picture. Spinal or epidural, they can be great options. Good targeted analgesia, maybe fewer systemic risks than GA sometimes, particularly if there are comorbidities. But you also have to factor in patient comfort, maybe anxiety levels, so sometimes a general anesthetic just makes for a smoother experience overall. How about you?
I'd agree. It's definitely a balance. Patient factors are key. Now, even before induction, something we can't really skip over is the pre-anesthesia marking.
Oh, absolutely critical.
You find marking those dilated veins, those incompetent perforators, while the patient's standing is essential, don't you?
Couldn't do without it. Gravity really helps map everything out, shows the true extent. And it's not just a quick sketch, is it?
No, it needs to be precise.
Right.
And you need that duplex scan with Doppler underpinning it. That mapping beforehand is just vital for a targeted approach.
Exactly. The duplex gives you that subsurface information, those perforators that, well, they'll cause recurrence if you miss them. It really elevates the surface marking into a proper surgical plan.
Right. So marking's done, patient's on the table,
Yeah.
positioning and draping next.
Yeah, the whole limb needs prepping, basically. Ankle right up, including the groin, perineum. You need that wide field just in case you need to address distal tributaries you found on the scan.
And the position itself. Supine, slight knee flexion, bit of external rotation.
That's the standard, yeah. Gives you the best access to the groin crease to the SFJ. Optimizes the view.
Okay, so incision time. The key landmark we're looking for is the saphenous opening, right? About 3 to 4 centimeters below and lateral to the pubic tubercle.
Precisely. That's our reliable entry point. And the incision itself, usually a horizontal one, maybe 6 centimeters or so.
Yes, placed within the skin crease if possible. Usually
Yeah.
gives a pretty good cosmetic outcome down the line.
And as you go down, you hit the usual layers: skin, subcutaneous fat, then scarpa's fascia, the superficial fascia.
Just need careful dissection through those. Good hemostasis sets you up for a clear view deeper down.
All right, now the main event, perhaps, exposing the great saphenous vein and that saphenofemoral junction. We expect the GSV medially in the incision.
That's right. Retract the edges, dissect proximally.
Hmm.
You're looking for that cribriform fascia covering the SFJ.
Carefully dissect around that fascia, and the junction comes into view.
You always have to remember, just deep to it, medially, that's the femoral vein.
Yes. A constant reminder of the anatomy there. Need to be meticulous.
The relationships are critical. Femoral vein, medial to the artery, often a slightly different color to the GSV. These are helpful cues.
Definitely. And you also need to watch out for the external pudendal artery. Sometimes crosses right between the femoral vein and the GSV. See that often.
It's variable, but it's something you learn to anticipate. Speaking of being careful, hitting the femoral vein inadvertently, that's a major risk.
Yeah.
Serious bleeding.
It is. If that happens, what's your immediate plan?
Well, first thing is get the head of the table down, right?
Oh.
Lower the venous pressure. Then direct firm pressure. Try and see exactly where it's coming from.
Absolutely. And no blind clamping. That's just asking for more trouble. You need fine control, polypropylene sutures for repair usually.
Good advice. Okay, so SFJ is exposed clearly. Next is systematically dealing with the tributaries. Key for preventing recurrence.
Agreed. You need to meticulously find and ligate the superficial external pudendal, the superficial external iliac, the superficial epigastric veins.
Smaller ones, maybe 30 or 20 vicryl, is usually sufficient.
Yeah, that typically works well for the smaller ones. And the main larger tributaries, do you tend to ligate those after transecting the GSV?
I often find it gives better visualization, yes. But there's one critical one you need to deal with before cutting the GSV.
You mean the deep external pudendal vein?
Exactly. That needs careful identification and, crucially, double ligation.
Yes, because if you don't secure that properly, you risk avulsing the femoral vein when you put traction on the GSV later, a potential disaster. Have you ever seen that happen?
Thankfully, haven't experienced it, but the risk Definitely highlights why that double ligation is so important.
Agreed. And to be really thorough around the junction, it's good practice to dissect the femoral vein, maybe 2 centimeters proximal, and distal to the SFJ itself.
Right. Ensures you haven't missed any significant tributaries connecting right there.
Mm.
Okay, so tributaries managed. Now for the GSV itself, ligation and division.
Standard technique, usually transfix and ligate with something like 20 Vicryl. Needs to be a flush ligation right on the femoral vein wall.
Flush ligation is critical. What are the main pitfalls to avoid there?
Well, the main thing is not leaving a stump. That can lead to a safena varix later. So
Yeah.
flush ligation prevents that pouch. Also, you must be incredibly careful not to kink or narrow the femoral vein when you tie that ligature down.
Makes sense. Do you add an extra ligature?
I often place an additional simple ligature just proximal to the transfixion one, just for that bit of extra security.
Okay. SFJ and proximal GSV dealt with. Now, attention turns down the leg to the remaining varicosities.
Exactly. Any of those marked tributaries like posteromedial branches or others off the GSV, if they're accessible, direct ligation is the way.
And for the ones extending further down, maybe to mid-calf, say 4 centimeters below the knee, near Boyd's perforator, what are the options there?
That's where you might think about stripping or perhaps ablation techniques, and this is a big but.
The saphenous nerve.
Precisely. You absolutely do not strip the GSV below the midcalf. The risk of saphenous nerve injury, causing neuralgia, it's just too high. It's a definite contraindication.
A point worth repeating. So if stripping is appropriate for those more proximal bits, how do you typically approach it?
Usually make a distal incision, maybe near the ankle, pass the stripper up towards the groin, secure it to the top end of the vein in the groin incision, and then strip downwards, pulling it out distally.
And elevating the leg during that stripping helps.
Yes, it can help minimize hematoma formation in the tract, less bleeding into the subcutaneous space.
Right. Okay, nearly there. Wound closure and post-op care. Just as important.
Definitely. Groin wound needs meticulous closure in layers. And if you made a distal incision for stripping, that needs careful closure too. Any small exit wound from the stripper needs suturing.
And dressings, bandaging.
Usually soft roller dressings on the wounds themselves. Then, importantly, elastic crepe bandages or compression stockings need to go from toes right up to the groin. That compression is key.
Reduces swelling, supports the tissues. Makes sense. And post-op positioning.
Keep the limb elevated on pillows, maybe 3 pillows, helps with venous drainage, minimizes swelling again, and like I said, elevating during stripping helps with hematomas too.
Excellent. Thanks for walking through all those steps. It's a procedure we do often, but like you said, revisiting the details is always worthwhile.
My pleasure. The Trendelenburg, it's still a very valuable procedure for varicose veins. Understanding each step thoroughly is just crucial for giving our patients the best care.
That concludes our deep dive into the Trendelenburg procedure. We've covered the nuances of patient preparation, surgical technique, and post-operative care. Consider these points in your next case. Thank you for listening to our podcast. See you in the next episode.